So welcome everyone to this webinar on eccentric exercise. I'm Andy Thomas and I'm Director at PhysiQuip, and I've been working with BTE Technologies for over 13 years. And during that time, eccentric exercise has been a growing trend within physical rehabilitation. So during this time as well, BTE have actually developed the Eccentron to address this need. So we're going to be talking about both of those things today. So the format for today will be that our speaker, Jeff, who you can see there, will be giving a presentation, and then we've got a Q&A. So hopefully you've all got questions already, or the presentation will stimulate those. So please put them in the comment section on the right-hand side. If you can leave your microphone on mute to avoid any background noise, that will help the presentation to go more smoothly. So our presenter today is Jeff Johnson. Welcome, Jeff. Jeff is an athletic trainer who worked clinically with elite sports institutions for several years before becoming a clinical specialist at BTE Technologies. So I will now pass over to Jeff, and thank you very much.
All right, thank you, Andy. Good morning. Well, good afternoon to all of you on the other side of the pond. That's what I did during my COVID time. Somehow managed to just focus on legs every day. No, that's actually one of our users out in Las Vegas, one of his patients, and a really good success story with Eccentron and using eccentrics. So I'm going to talk to you a little bit more about eccentrics. We all have a very good understanding of what eccentric exercise already is, but I always find it really helpful when we go through this presentation around the world that I just give some people some reminders, because I think that there's a little bit of a misconception in some areas that eccentrics is dangerous. It's maybe a little bit too much for certain populations, but really it's quite advantageous to quite a few different human populations. Really, the concept of eccentric exercise has been around for quite a while. It was first documented all the way back in 1882, and then we started seeing more of it being documented through the literature in the 1930s and then into the 1950s. The original term eccentric was first mentioned back in 1953, and we now refer to it more as eccentric, but it just simply means moving away from the center. So a few interesting injury stats that I always like to go through. These are types of injuries that we all are going to deal with, and we're going to see hamstring strains, we're going to see muscle strains, we're going to see tendon strains, Achilles tendon strains, and then ligament injuries. And the most common one that we'll talk about is going to be the front ligament or the ACL ligament in the knee. But hamstring strains, they are a significant amount of the time that we see spent focusing on rehab, especially for the athletic population. As you can see here, they account for 12% of all injuries in the English Premier League, and that's going to sideline someone for over 2 weeks. And if they're lucky, they're going to come back, and hopefully they're not going to have a reoccurrence of the injury throughout the season. But from my experience, it's been when you have a hamstring injury during the middle of the season, it seems to always kind of just be there in the background with that athlete until you can really focus on resting while rehabbing at the same time. Tendon injuries, one in particular that we see a lot of, especially with the lower extremity, is going to be the Achilles and patellar tendon. Some success stories have been shared with those users who have an Eccentron for those types of populations, so we can cover those as we go through. And then the most research, what everyone loves to talk about, especially here in the States, is the ACL injuries. And how do you rehab an ACL? How do you treat an ACL? So we've got some very good information to share with you on that. But what's unique about all three of these types of injuries is that the eccentric phase of contraction has been shown to be one of the primary culprits of these types of injuries in quite a bit of research. So just a quick reminder of the difference between a concentric and an eccentric contraction. A concentric contraction, we're going to shorten the muscle, pull it more towards the body. During an eccentric contraction, we're going to be lengthening the muscle under load. We're going to have a significant number of cross bridge formations in the muscle fibers. That's going to allow us to produce more force. Back to probably the first 2 weeks of your biomechanics class in university is the force velocity curve of a muscle. And as we can see here, the eccentric phase of the contraction is going to be what's going to produce the greatest amount of force for you. Now, as a proponent or as a component of generating higher force, you're typically going to work at a lower velocity. When we're looking at Eccentron, and I'll talk more about Eccentron in a bit, what we're looking at here is the ability to change speeds from very slow to very fast. So you can actually control this force curve a little bit further. Now, the higher speed that you work at, you're going to probably see a decrease in the amount of eccentric load, but you're still getting quite a few reps and you're still getting quite a bit of work eccentrically loaded into that part. So I'm going to go through just some of the qualities of eccentric contractions, what they can do. One of my favorite things to point out is that the eccentric phase is when you're focusing only on the eccentric phase anyway, you're going to be doing a lot more force, but you're also going to be doing more work. And I'm going to come back to that concept of work a few times. During the eccentric phase, we're looking at around 30 to 35% more force being applied to that muscle group. And when it's closed chain and seated, you're applying all of that force through the entire lower extremity kinetic chain. So big advantage there. But as a product of working under higher loads, muscles are going to adapt. What do muscles do? Well, they respond to the load that's placed upon them. Wolff's law says that if you load a muscle, if you load a joint, if you load a ligament, a tendon, then those structures are going to respond based on the load that you're putting them under. So if you put them under a greater load, they'll typically respond very well. And they'll do it in a quicker period of time. Since you're working under higher loads, you're doing more work, muscles are going to get larger, but muscles are also going to get stronger, especially when you compare that directly to concentric exercise. But with muscle loss, what this all means is when you have muscle loss, you're going to have a loss of something, and you're going to have atrophy, loss of muscle size, you're going to have a loss of balance. And as we know, especially as we age, when we lose balance, that's when we become a fall risk. And a fall risk can ultimately lead to even more comorbidities and even premature death in some cases. So there's a very low RPE associated with eccentric exercise. And one of the easiest analogies to think of here is when you walk up steps. If you put 25 kilos on a sack and you walk up 5 flights of stairs, by the time you get to the top of those stairs, you're going to be slightly winded. You're going to have a little bit shortness of breath. But if you turn around and instead of 25 kilos, you load 50 kilos into that same bag and you walk down the same number of stairs, that RPE is going to be very low. You're not having to create the energy. You're absorbing the energy as you go down the stairs. You're not having to tax the cardiopulmonary system. You're just working muscles when you're looking at the eccentric phase. And as a result, once again, you see here that work is capitalized, and work is the fundamental way that we get stronger. Do more work. More work is more force. More work is more force through distance. It's a greater number of repetitions. So ultimately, we're always going to be doing more work when we load more eccentrically. There is a very low energy requirement of the body. As I mentioned, that you're taxing the cardiopulmonary system much less. It's been found that you're actually reducing this by about 80% when you compare it to concentric exercise. So for certain populations, they can't really metabolically work at a high rate. So what do you do with those patients? Well, you've got to find something that's going to overload their muscles, their tendons, their ligaments, so that they can be more functional. And a great way to do that is to load them eccentrically. Here's a little example of looking at work and looking at total force. So what we see here is 2 yellow circles. The yellow circle on the bottom, that shows that this person is working at 180 pounds. That's per leg. And since we're focusing only on the eccentric phase of movement, we're only going downhill, we're not doing uphill. We can do a lot of repetitions. So if you look at the top circle, I have 142 reps circled. That is per leg. So in this individual's case, they're doing a significant number of repetitions in a relatively short period of time. And we'll come back to this screen a little bit later. Another product of what eccentric exercise is going to do is it's going to create a tighter or a stiffer muscle fiber. Now, some people think that stiff and tight in muscles is not necessarily a good thing. And yes, if we have very tight hamstrings and we can't touch our toes, then we need to work on our hamstring flexibility. That is different than when you're looking at the stiffness of the quality of the sarcomeres and the internal fibers. So what we want to see is that those fibers, that they get stiffer and stronger so that we can generate more force, that we have the ability to respond to outside stimuli quicker and easier. It's easier for the muscle to contract. When you're exercising eccentrically, not only are you improving eccentric strength, but you're improving concentric strength and isometric strength. When you exercise isometrically, you're only going to improve isometric strength. And when you exercise concentrically, the vast majority of those gains are going to be concentric and isometric. Very little eccentric strength gains are going to be noticed with that. But with the eccentric exercise, you're going to see that, that this is going to lead to an improvement of all 3 of those phases of contractions. But in particular, the eccentrics is going to create a stiffer stiffer joints, stiffer muscle fibers, which are going to lead to a more stable joint. And as we know, a more stable joint is a healthier joint and a joint that can generate more force. As we age, as we know, we lose these type 2, these fast twitch muscle fibers. They're very difficult to get back when we start to lose them. You know, really in your 40s, that's when they're going to start to disappear, especially if you're not training them very often. But as we get into our 50s and 60s, when sarcopenia and osteoporosis come about, the loss of those type 2 fibers is going to be even more pronounced. So when we lose these type 2 fibers, we're not going to be able to change direction as easily, walk down steps, down stairs, run, slow down, stop. All of those movements are necessary, and those movements are controlled by the type 2 muscle contractions. And where this applies to athletics is, think about the number of sports where you see non-contact injuries that occur. So a hamstring strain or an ACL tear in football. Most of those are going to be non-contact related, and that's typically because of a change of direction or a change of speed that's going to occur. And then as we get older, so we're now in our 60s and our 70s, we're walking in our house with groceries in our hands, and we may have a pet that runs in front of us. Well, if we don't really have those good type 2 muscle fibers, then we're not able to really respond to that outside stimuli, and we may trip, we may slip on that pet. Also worth pointing out, there is a difference in eccentric contraction if you're working in the open kinetic chain or the closed kinetic chain. Both are very advantageous for rehab. You have to do both. It doesn't matter what type of person you're working with. You need to focus on both an open and closed kinetic chain. Closed kinetic chain is typically more functional than open kinetic chain, but the open kinetic chain is going to allow you to isolate individual joints by themselves. So on that open chain, we look at a knee extension. Knee extension, it's great for really firing that VMO muscle in the quads. You're able to really see if a person's contracting effectively. You can do it on one leg, you can do it on both simultaneously. There is a mechanism that occurs internally within the knee. So if we're looking at osteoarthritis, or if we're looking at a person who did have a front ligament, ACL ligament tear, the last 15 to 20 degrees of knee extension, we're going to have that rotation, that screw home effect that occurs within the knee. And for those patients who do have a weakened joint, that can create some flare-ups, that can create some pain and some problems. So in those cases, the open kinetic chain may not be very helpful for those people, because you're actually creating more harm than you are good. So going to a closed kinetic chain, like a seated device like the Eccentron, or a standing squat, or a seated leg press. And what we also can see with a closed kinetic chain versus an open kinetic chain eccentric contraction is that we're able to generate significantly more force in a closed kinetic chain manner. This is a study that came out of Switzerland a few years back in the Schultes Clinic. And what they found was that people who were exercising on Eccentron were able to generate 30.5 newtons per kilogram of body weight. And then when they compared that to an open kinetic chain, like a seated knee extension, they were only able to generate 10.7 newtons per kilogram of body weight. So you're looking at 3 times advantage of muscle force when you go to a closed kinetic chain. And once again, that's because the joint is fixed to a position, and you're able to create more stability within the joint, which is going to allow you to create more force. And also reduce the risk of injury. There are quite a few studies out there that talk about the eccentric phase being the culprit or the instigator to these injuries. So when you can actually introduce more eccentrics early on, so before an injury occurs, you should be able to reduce certain types of injuries. Some things that occur, you're not going to prevent every injury, but you can certainly reduce the risk of those tendon injuries and muscle injuries. And people that you flag early in the season as having a deficit in either their eccentric phase of contraction, or maybe they have a noticeable size difference in quads. So those are people that you can flag early on and perform some prehab with those people. So we talked a little bit about Eccentron. So what exactly is it? Eccentron is a closed chain seated recumbent eccentric exercise device. And so the picture that you see here, your client's going to be seated, and then the pedals are going to move. As those pedals move, as the pedal travels towards the patient, towards the client, they're going to resist the pedals. They're going to slow the pedals down, try to stop the pedals. And by doing that, the hamstrings, the quads, the glutes, all those muscles are going to be lengthening under tension, and that's your eccentric phase. As the leg travels back out to the start position, you're not going to be applying any force, so you're eliminating the concentric aspect of the movement there. It's a very unique movement. I always try to say that it's at first when you put someone on there, that they're not going to get it immediately. It takes a few repetitions because you're trying to train them in a way that they've never trained before. Some of the most elite athletes in the world at Manchester United or with our professional football and basketball teams here in the States, they get on there and they're like, whoa, it's like if I'm trying to turn a bike to the left, but in order to turn it to the left, I have to turn the handles to the right. Your brain is not really wired that way. So we have to work through that motor aspect of learning. Typically by the end of the first session, most people get it. Even your frail patients, those patients can tend to pick up on this pretty quickly. So a little bit more about what Eccentron is it's going to allow you to look at only the eccentric aspect of movement. We can completely eliminate the concentric phase. When we eliminate the concentric phase, we actually are reducing the risk of more significant DOMs. One of the complaints that we hear about some places with eccentrics is that they don't want to create delayed onset muscle soreness. Well, muscle soreness is not always a bad thing. You have to have some level of inflammation in order to have the hypertrophy phase start to kick in. And a little bit of soreness is the product of that. So with when we're doing only eccentric exercise, we can eliminate some of the more aggressive metabolic cost that occurs in the muscle from the concentric phase as well. I mentioned this is closed kinetic chain. You can isolate each leg individually. So if you have a case of a person who may be an amputee, maybe they only have one extremity, you can certainly focus on the glutes for that good healthy leg. But what you can also do is to teach someone to help train them for some motor control, just focus on one leg at a time. We find that to be very helpful. This is not only strength training, but you're working on neuromuscular training. So you may have a neurological patient, someone who's been in a motor vehicle accident, who's had a brain injury. They would certainly be a good candidate to do this because we're not only strengthening, but we're also reteaching how to fire certain muscles. We're doing a lot of work, high volume of repetitions. You can make it easier, you can make it more challenging. It's up to you as a clinician how you want to move forward with your program. And even as something as simple as narrowing a target window, so if you give someone 40% room for error, if you knock that down to 20% room for error, and you keep every other variable the same, the adaptations that a person makes within a week are still quite significant. They will feel the difference right away. A few of the specifications, the seat height, it's just slightly above the standard wheelchair height, so there's going to be slight ingress there. The machine does weigh 340 kilos, which that's the max resistance of each leg. I've seen in my near 8 years, I've seen maybe, I would say close to a dozen people actually achieve that. It doesn't happen often, and it's not always the people that you think. It's not always those elite athletes who have done this. But it's quite remarkable to see that they can generate that much force eccentrically in one leg. The pedal speeds, 12 to 48 strides per minute. This is going to allow you to focus on a contraction from anywhere from 0.6 seconds to 2.4 seconds. So if I have a person who has a glute deficit, they really have a lot of low back pain, and we see that it's because the glutes are just so deformed, they're weak, they're just not there. If I want to turn those glutes on, I'm going to lower the speed of the pedals to about 12 to 14 strides per minute. I'm going to make them hold that contraction for 2 seconds. I want them to feel what it's like to engage that muscle group, but also to hold it. And you'll see some pretty quick changes from people when they do that. A few screens here to share. On the top left, we have what's called the dosing test. And this is really key. And this is something very important on Eccentron. During the dosing test, we want to make sure that we're loading someone correctly. We're loading them safely and effectively. If we load someone with too much force, we're going to create significant DOMs, and they may not want to do a second session. They may not walk for the next 2 days. We don't want to do that. So what researchers have found with this is that if we dose only the eccentric phase of movement, and we go to 50% of that, and we do our first session at 5 minutes, then we're going to see an inflammation response, but we're also going to see a positive pain, positive RPE. People aren't going to be so uncomfortable they can't do this again. They'll typically come back 2 to 3 days later and do a second session. And if any of you are familiar with the repeated bout effect, what that says is that when you've been exposed to some muscle soreness, to some muscle injury associated with eccentric contractions, give that to them again within the first 72 to 96 hours. And by doing that, that third session, that fourth session, DOMS is almost non-existent at that point. But it all comes to the dosing. Dosing is really important on this. The second screen in the top right that you see here, this is the treatment screen that the patient is looking at during the exercise. The pink bar represents the left leg, the purple bar represents the right leg. And during the treatment, what we want to see is that each of those bars gets into this yellow window, yellow or green window, and that shows good motor control. The third and fourth screens that we see on the bottom here, these are session reports. What we want to do is we want to look at the difference between the left and right leg. We want to look at symmetry, balance. If one leg is able to stay within the target range, but it's generating 500 more newtons per repetition, well, there's a significant difference in the ability to control force on a left versus right leg case. So during all of my presentations with the Eccentron, one of the things I like to point out, and one of my biggest points, is that of all of the research that exists with the Eccentron is so unique, and that it shows how this device has been used in comparison to a traditional method, or to more concentric exercise, or to leg presses. So you've got a true control group with these. These are control studies that you can actually look at two treatments and find which outcome is better to the patient. And the vast majority of our research, 90+%, 95% of our research that independent researchers have conducted, they're looking at how Eccentron applies to this particular population, but how that population responds to the eccentric exercise on Eccentron versus a traditional method. I'm going to go through these quite quickly. Andy can share the presentation later on with you if you would like, which has all of the references. I'll also include what's called our evidence-based initiative. Every quarter of each year, we update this. So anywhere that Eccentron has been used in research, we throw that into the abstract, and it's available on our website. So the most common places in research where the Eccentron has been used has been in ACL. Typically, clinicians are going to introduce the Eccentron anywhere between 10 days and 21 days post-operatively. If you have meniscus involvement, you're probably not going to go on the Eccentron for at least the first 3 weeks. If there's no meniscus, we're finding great results with putting someone on at 10 days post-operatively. They're not working at a heavy load. They're not working at their max capacity, but the pedals are moving, and they are starting to generate some force through the lower extremity kinetic chain together. But a couple studies here where they looked at an ACL population, and what they saw with both of these studies, and there's even more studies that are out there with this, that work rates increased. And while work rates are increasing, pain is not going up. Pain's not going up, so quad strength, hamstring strength, all of these things are improving. Over the course of a 12-week session, and most of these are going to be 12 weeks. That's kind of like the standard for the Eccentron research. In these 12 weeks, what we're seeing is that in the bottom case here, that the quad volume increased 25% for the Eccentron group, whereas the traditional exercise group, they improved only 8% of their strength. And also after a year post-operatively, we saw that those people that exercised on Eccentron, they maintained those same strength levels than those that worked out more in a traditional concentric and traditional rehab method. More ACL research, I'm not going to go through that necessarily right now. Cardiopulmonary patients, typically these patients, they're not able to do a lot of work because obviously the lungs, the heart, something is not working quite right. So they're not able to really get their MET levels up to a nice healthy level for those muscles. But in both of these studies, what we see is that oxygen uptake was found to be lower than in traditional concentric exercise, which is great because we're doing more work. Remember, we're working at 30 to 40% more force, but if we're doing that and we're working at the exact same O2 saturation level and the exact same heart rate, then we're getting a lot more out of our workouts. Another population that's really susceptible to exercise is going to be your diabetic population. And I know here in the States, this is a big area of research right now. There are a lot of folks that are focusing on different types of eccentric research for this population because it's starting to show that there's pretty good evidence that says that eccentric exercise is very effective in keeping the A1C levels, those are those insulin sensitivity levels, at a nice stable rate so that a person can do more exercise during the course of the time. See a lot of knee replacements, hip replacements kind of around the world. You know, that's not something that's unique to the US, but in this case, the total knee patients They started this program typically about 6 weeks, anywhere between 2 and 6 weeks post-operatively. Physical function was increasing significantly during this 12-week training program. We're getting a much larger bit of hypertrophy in the quads, hamstrings, and glutes than we would be in a traditional control method, traditional exercise. Parkinson's patients, this is somewhat of a unique area of research. Can't wait for more research to come out here related to this subject. But what we see is that in Parkinson's patients, they too, once again, are unable to really do much volume of exercise. But here we're able to get them in a seated, comfortable position. We exercise up to 20 minutes for this population. And over the course of the 12-week program, what we saw is that the internal torque of the knee increased 30% versus 0.7%. I would say that's significant. But more importantly, function, physical function, the ability to get through day-to-day activities was easier. So stair descent improved in these cases, as well as ascent going those steps. Another population, cancer population, once again, they're frail due to the chemo, the radiation that they're receiving. So we keep the MET levels low, and we're able to do more exercise, more volume of work here. One that's relatively new to us is just a few years ago, a small university in Tennessee. They stumbled across our product during a presentation for their doctoral students. And so they decided that they would eventually move forward with a purchase because they wanted to do a study with this population of spinal cord injury patients that has never been done before. So they, what they did was they first introduced 6 patients to a 12-week training program on Eccentron. And over the course of the 12 weeks, these patients worked out twice a week, and they would go up to 12 repetitions per leg. They would take a 30-second break, and then they would keep doing this. They would do this for 20 minutes. And that walking mobility improved. But what's more important here is that the people that had these incomplete spinal cord injuries, not only were they walking better, their walking speed increased. And as walking speed increases, fall risk goes down. The use of outside devices, walkers, crutches, those were decreased. One particular person, we went there and wanted to meet with these researchers because what they were doing was so unique. And this one particular person, she was falling anywhere between 6 to 10 times a day before she started her Eccentron session. And this was going on for years. She couldn't even count the number of times that she broke bones in her hand and her arms from the falls. And in fact, when we were there, she was still wearing a splint on her wrist from a recent fall. But anyway, so the Eccentron, when she was working out on that, she found that she was falling 2 to 3 times a week versus 6 to 10 times a day after that. So she noticed that this changed her quality of life, that she didn't have to worry as much about falling. And she was ultimately able to continue to come into this university to do exercise. And the last we heard, she's doing great, very independent. She doesn't use a walker at all. She very rarely uses a cane. And she's even working back with horses. So a really unique case of this person who saw benefits from this. There's even some evidence that shows that using the Eccentron, doing eccentric exercise is a prehab method, can be a way to prevent hamstring injuries and to prevent knee injuries. So in this case, we had 61 university teams that participated in the study. Over the course of the season, they saw that there was a 74% lower injury rate in the hamstrings and a 58% lower ACL injury in the eccentric group. Sports performance. We could keep going on and on and on about all of these studies. But for sports performance, this is not necessarily just a rehab device. This can be used for prehab. This can be used for training, working on muscle power, force production. And in this case, just a 6-week training program elicited 5-centimeter vertical jump improvement in this population. If they continued on for 12 weeks, who knows, maybe that could have been 8 centimeters, 10 centimeters. Which is quite significant. And that can be the difference between playing, high school basketball versus possibly college or even in professional basketball. There's more studies that are going on. That's the beauty of a device like this, is that it's easy to perform research. You're able to capture raw data with the analog outputs that we have on the device. So researchers love it. There's countless other research studies that are going on right now. It's being used in every type of facility, from elite, as I mentioned, Manchester United, Houston Rockets, professional football in America, to very frail places like skilled nursing homes and rehab facilities that deal with patients who are old but very frail, and everything in between. There's really no contraindications to this outside of the joint just being relatively stable. You can't do this 3 days post-op ACL, but certainly 2 weeks to 3 weeks post-op, you can bring those athletes in and those patients in. So that's really about all I have at this point. And we're going to open the forum to questions and any thoughts that you all may have.
Great, thank you, Jeff. That was really interesting. So just to get some engagement, and you brought up a couple of points there. So we're going to run a poll. So if everyone could answer the 3 questions that we're going to put up now. So you mentioned about conditioning and rehab, and it'd be interesting to get the feedback of, of what people are using it for, and then how often eccentric is being used currently, and then also if technology is being used. So if you could answer those, that would be great. Okay, and I'm just going to share the results of that now. Hope this gives you some context, Jeff. Right, yeah, well, that's good. It's being used in both, and it's being used. So that's I guess that's why people have tuned in. So that's always helpful. And yeah, mainly people not using technology, Jeff. So from your experience in the US, how do you find it? Like, what were you doing when you were working clinically? What were you using tools? How are you doing your eccentric rehab and work?
So I didn't have access to an Eccentron. I did a lot of isolated standing on steps, doing slow descents, really hammering those glutes. Using a leg press was nice. But then again, with the leg press, if I tried to load heavily, then I would have to somehow push that sled up or have my patient work on that concentric phase. So certainly there's a consequence to that. If you're going to use traditional methods, then you're maybe going to have to work harder, work more one-on-one with that person. What we find with Eccentron is that it's relatively independent, that once you put a person on and they go through that session, they start to understand the concept and they learn the motor control aspect. They tend to be pretty independent and can do this session on their own. One of our users out in Las Vegas, he's actually a practicing clinician, but he also is a researcher. He produced a study a few months back that looked at EMG activation for those patients on Eccentron versus those patients not on Eccentron. So trying to do like a traditional standing squat, looking at EMG data, comparing that to what happens on Eccentron, how much hamstring activation, quad activation do you get? And he found that there's exponentially more activation on Eccentron than any of the other traditional methods. There was still contractions that occurred, but they were nowhere near the intensity that they were getting on Eccentron. And that's a study that you can find on the evidence-based abstracts that we produce.
Great, thank you. Got a question that's come through on the chat. So are isometric loading exercises as effective as eccentric loading exercises for hamstring injury prevention?
Isometrics are great, especially early on from an injury. The challenge with isometric exercise is that if you're going to train through the entire range, you have to train at each angle. It takes a lot of time and a lot of repetitions to do that. Isometrics, we know we can generate very high force, but we're not doing it in a dynamic manner. We're just doing it in a static manner. Eccentrically, you're going to load significantly more. You're going to load it through range. So when you look at function, even something as simple as just walking, not even for a sports team, but an athlete, but if you're looking at just walking, then that's functional and you want it to move through range. That's a good question though.
And in terms of that loading system then, so does the system offer a concentric angle as well, or is it just eccentric? And if not, why not?
You certainly can. So as a pedal is traveling away from the person, they can load concentrically if they want. The machine is not necessarily measuring that. If you're looking at raw data output, you can see that on the raw data, but the patient is looking at just the eccentric phase. So as the pedal is traveling back towards the client, what they're doing is they're applying a force, hopefully within a target range. Their feedback that they're seeing is immediate. They're either going to be giving too much or too little force, and they then scale it accordingly. With Eccentron, you're gonna isolate just that eccentric phase, and we want to eliminate the concentric phase so that we can do more repetitions. We find that the more reps we do through that range and under the higher load, that's going to give us more work. And if you recall, the definition of work is just a product of force times distance. So how much exercise is done. So we're going to do a lot more exercise if we do just the eccentric piece.
Yeah, no, it makes sense. You just get a bike otherwise, and you can incorporate that into there. So we've seen a lot of research in the older adult over here. I think a lot of that is driven by that there's a lot of funding out there for that, rather than the athletic. Have you seen any correlations between those type of patient groups being transferred into general and also athletic?
What was the first part of that? You broke up a little bit. Did you say older?
Yeah, so the older adult, there's been a lot of research over here in some of the institutions in Leeds and Northampton University. They've produced some really good published papers that have been presented at various different seminars. And did you see any sort of correlation between that and how that transfers into the general public and athletic population?
Well, whether you're an athlete or not, those of us that are in just general orthopedics, we're going to treat non-athletes just as much as we'll probably treat athletes. And we all respond, even though we're all unique, we all have our own ways of moving and performing exercises. We're all somewhat the same in that we respond to stimuli. You know, Wolff's Law, you respond to the force, the outside stimuli placed upon the structures. So we're all going to make some level of adaptation to eccentric exercise. And for some people that adaptation could just mean that they're going to be a lower risk for a fall. And for another person that could mean that they're going to be able to return to playing football with lower risk of injury, even though they did have a previous injury. The fact that they trained so much eccentrically post-operatively, they've worked on that deficit that maybe led to that injury in the first place. Certainly all populations are candidates for this, and not necessarily just performance or just rehab, and anywhere and everywhere in between.
Okay, great. We had one that was pre-submitted. So if the first sign of the patient using the machine is a painful one and discomfort, what do you do then? Yeah,
great question. The experience that we want someone to have when they're done with the Eccentron is the muscles feel a little tired. And then the next day, we want those muscles to feel somewhat tender. So if you're palpating the glutes or the hamstrings, we want those muscles to notice something. I would say that my first session is probably similar to most people's first sessions. I felt it in my calves because we put it on a session setting that allowed me more dorsiflexion. So I felt a lot of gastroc soreness that following day. But where I noticed it the most was my glutes. And I don't think I'd ever felt so much of an isolated tenderness in the glutes, but it was functional. So I could walk the next day. I could walk upstairs, downstairs, and it was not that DOMS that we associate with really heavy load eccentrics. Part of what makes that DOMS so bad in the traditional, like when I go to my gym here, I see someone doing a very quick concentric and then doing a very slow negative, very slow eccentric. They're doing maybe 8 to 12 repetitions, if that, under a heavy load. They're going to be pretty sore the next day. I think those of us that have done this can all relate to that we have trouble reaching up and grabbing the soap and shampoo in our shower. But with Eccentron, it's very rare that muscle soreness is so extreme that it causes pain the next day. We do want there to be soreness. That shows that we are working muscles, in a unique way. And that's typically like an aha moment. That's where a patient will realize that, wow, I've really done something different here. And as mentioned in the presentation, that repeated bout effect, reintroduce that a couple of days later, and the risk of DOMS goes down yet even further. But the key comes back to the dosing. And if you don't dose safely, if you tell someone to give me all of your max effort, try to kill the machine, you may have a person, if they're really motivated, that is going to generate so much force that they may create some soreness for themselves. We don't recommend that. We recommend that the dosing is very strong, but not 100% max. We want it to be comfortable and tolerable. And you'll notice that pretty quickly when you get into the exercise. If a person just can't get to the target range, then at that point, you know that, that you dose them too high.
Okay, great. Another question here. So what is your stance on shockwave and eccentric training for tendons? Shockwave is really prominently used over here for tendons. So what's your thoughts? Do you use shockwave in isolation with eccentrics, either or? What's your thoughts?
I can't really speak too much to shockwave while using it with eccentric exercise. We have a couple of clinicians out there who would probably be better resources for that, because I'm not a practicing clinician anymore. I haven't used shockwave on patients, but I would imagine that you're going to see benefits since they are using them in conjunction together. We see more in blood flow restriction being used with Eccentron. You can actually see quite a few videos online. There's one with Dwight Howard with the Houston Rockets who's using BFR with Eccentron. So there's evidence of that.
Okay, great. Another question coming through. Is there any evidence or have you any experience regarding the use of eccentric cycling training preventing hamstring strains in football athletes?
Yes. So one of the slides was related to eccentric training in a football population and hitting them before the season. And that study showed that the numbers were 58% fewer ACL injuries and 74% fewer hamstring injuries in those teams who trained eccentrically before the season compared to those that did not.
Okay, great. One thing that came to me when you were talking about the oxygen consumption is the COVID-19 patients. Have you had any experience of that with the Eccentron?
Well, certainly. I mean, that's around the world. We're all struggling with patients who have been deconditioned. But every day that we're in a bed, we're losing 15, 20, 25% strength. And some of these COVID patients have been bedridden for a significant period of time. We're talking maybe 2 months in some of the cases that I've heard. And that's going to have a consequence of lack of function, lack of ability to stand. We do have a couple of these devices that are in rehab facilities, so the long-term and short-term rehab facilities that we call it skilled nursing here in the States. And they're using them as often as they can, and they're using them constantly with patients. Not even the ones that have just been COVID hit, but the ones that haven't really been able to do much because they've closed therapy services in some of those cases. They didn't have large therapy sessions. They were maybe only bringing in one patient at a time, whereas some of these facilities, you'll go in and there's 15, 20 patients working out, going through an exercise program together. Yeah, it's been used heavily in our rehab facilities here.
Yeah, we've actually got a session which is on another piece of your equipment, the Primus, which is going to be addressing how a hospital actually uses it for their COVID patients from that remote management, but using the data from that system. So we'll send the information out when we've got that one. But it's definitely a huge topic at the moment.
Yeah, it'll be nice to get more than just the anecdotal evidence that, oh yes, it's working, we're using it often, but to actually see that, hey, yeah, our COVID patients that we've treated with this are now, in 3 weeks, they're 80% stronger eccentrically. It'd be great to get some objective documentation about that.
Yeah. Great. Well, that's all the questions. Anything else you want to finish on, Jeff?
No, if you have the opportunity to see one, to get on one, I highly recommend you do it. It's such a unique, aha, whoa, what is this moment that you can talk about it, you can understand eccentrics, you can love eccentrics, but until you actually get on it and feel it, it's really difficult to make it come through during a presentation or even the YouTube videos that are out there. So if you know someone who's got one, or if you're around a place that has one, ask if you can use it.
Great. Can you just go on to the next slide, Jeff, and we'll just update on the upcoming events we've got. So we've got a couple more events coming up. So Ken, who was actually on the meeting earlier on and has got 4 Eccentrons in his unit in the United States, He's going to be presenting for us on comparing and contrasting cupping with targeted negative pressure for the management of MSK conditions. Ken's a great speaker, uses a lot of technology within rehabilitation. So that is on Tuesday, the 8th of September at 6 p.m. Definitely recommend that one. And then we've got another session with you, Jeff, which we're looking forward to on Friday, the 11th of September. And that's talking about cervical strength. So is strength a missing link in neck pain? Don't give us any answers now, Jeff. We'll wait until the 11th. But other than that, I'll say a big thank you to you, Jeff, and thank you for everyone joining us. And we look forward to seeing you soon. We're going to send a feedback questionnaire, so if you could fill that in, that really helps us to improve these sessions and make sure that we're catering for the demand of what you need. So thank you, Jeff.
Thank you. Thank you for attending, everyone. Thanks.
No problem. Right, have a good afternoon. Bye-bye.